Welcome to another deep dive. And when I say welcome, I am talking directly to you.
Right. I mean, the nursing student.
Exactly. The dedicated learner who is, currently living on stale coffee, navigating the absolute gauntlet of clinical rotations, and just staring down the barrel of the NCLEX.
We absolutely see you.
We do. You're looking at this cowering stack of week 6 clinical notes, pharmacology tables, and evidence-based practice guidelines surrounding cardiovascular disease.
And trying to figure out how to translate all of that from a textbook into actual life-saving practice.
Right. So our mission today is completely tailored to you. We're going to trace the pathophysiology of coronary artery disease, decode the ischemic spectrum of angina, walk through the terrifying tipping point of acute coronary syndrome.
Which is a huge topic on its own.
Oh, massive. And finally, we'll navigate the incredibly high-stakes world of post-ABG ICU nursing. But we're not going to just read bullet points at you. What is the best way to test clinical judgment?
You throw the learner right into the deep end. We strip away the safety of the multiple choice format and put you virtually into the patient's room. Because real clinical knowledge is only valuable when you can apply it at 2 o'clock in the morning when the alarms are going off.
So true. So picture this. You are on a busy, step-down medical surgical floor. You've just received your assignment for the shift, and you're taking over care for a 58-year-old female patient.
Okay.
You do your initial chart review, and here's your baseline. I'm looking at her vitals and labs. Her heart rate is sitting at a tachycardic 115 beats per minute.
A little fast.
Yeah. Her respiratory rate is elevated at 24 breaths per minute. Blood pressure is hypertensive at 155/95.
Got it.
In her history, the chart shows primary hypercholesterolemia with significantly elevated LDL levels. As for her active medications, she's taking atorvastatin, and she is wearing a nicotine patch as part of a smoking cessation plan.
It's an incredibly realistic patient profile. I mean, you have multiple risk factors converging here. Age, lipid profile, history of smoking, hypertension.
Right. So you're at the nurse's station charting when suddenly her call light flashes and the telemetry monitor shows her heart rate spiking.
Not a good sign.
You walk into a room and the atmosphere is completely shifted. She is gripping the bed rails. She complains of a severe strangling sensation high up in her chest.
Okay, classic presentation.
She is extremely dizzy. Her skin is pale and completely diaphoretic. I mean, she is sweating through her gown, and she looks you in the eye and tells you she feels like she's going to die.
That feeling of impending doom.
Exactly. Crucially, she has been resting in bed for the last hour. She hasn't been up walking around.
That is a very important detail.
Right. So here is your classic NCLEX-style priority question. Listen carefully. Based on this presentation, what is your priority nursing intervention? Is it option A, administer a sublingual nitroglycerin tablet? Option B, stop all patient activities and assist her into a semi-Fowler position? Option C, draw serial cardiac biomarkers to rule out acute coronary syndrome? Or option D, begin continuous observation of the cardiac monitor for arrhythmias?
Okay, do not just jump to the medication.
I know it's tempting.
It is, but we need to pause and do what a seasoned nurse does in that fraction of a second. We analyze the clinical picture structurally. The very first question to ask yourself is, what is the main problem here?
Right.
We have a patient with severe strangling chest pain, diaphoresis, a feeling of impending doom, and it is not resolving with rest. The main problem is acute myocardial ischemia. She's exhibiting the hallmark signs of severe unstable angina or potentially an evolving acute coronary syndrome.
So we take that main problem and run it through our prioritization framework. Is this an airway, breathing, circulation, safety, or psychosocial issue? We always fall back on the ABCs.
This is fundamentally a circulation issue. The coronary vessels, the pipes that actually feed oxygen-rich blood to the heart muscle itself, are critically narrowed or blocked.
The myocardium is literally suffocating.
Exactly. Which brings up the third analytical question. What is the most immediate risk to this patient right now?
The immediate risk is myocardial cell death and infarction.
Right. If that heart muscle dies, you are looking at an irreversible cascade. The heart loses its ability to pump, leading to critically low cardiac output, acute cardiogenic shock, or sudden cardiac death from a lethal arrhythmia.
So our final question before we act down. What intervention actively prevents that deterioration? Our goal has to be decreasing the amount of oxygen the heart needs while trying to maximize whatever oxygen it is currently getting. We have to reduce the workload.
Based on that exact clinical rationale, the correct answer is option B. You must stop whatever the patient is doing and assist her into a semi-Fowler position.
Option B. I guarantee a lot of nursing students just mentally chose option A.
Oh, absolutely. They saw chest pain and immediately thought of the nitroglycerin sitting in the pyxis.
So why is physical positioning the absolute first undeniable priority?
Think about the physics of the human body. When a patient reports ischemic pain, the immediate goal is to physically reduce the workload on the heart. If you sit them up in a semi-Fowler position, usually about 30 to 45 degrees, you decrease venous return to the heart. Gravity pulls the blood volume down into the legs and lower body, meaning the heart doesn't have to stretch and pump as hard to manage that incoming preload.
That makes perfect sense.
Simultaneously, sitting them up drops the diaphragm. That optimizes lung expansion and improves oxygenation naturally. You are physically intervening to drop the oxygen demand before you even touch a medication wrapper.
Let's break down why the other options are either unsafe, delayed, or just outside the scope of priority intervention. Option A, the sublingual nitroglycerin. It's a vital medication, but why does it come second?
You cannot hand a potent vasodilator to a patient who is actively panicking or sitting in a compromised position. You must establish a physical baseline of rest first.
Right, because of blood pressure.
Exactly. If you give nitro while she is flat on her back or trying to stand up, you risk a catastrophic drop in blood pressure paired with increased physical exertion. You secure the patient physically, then you treat pharmacologically.
What about option C, drawing the serial cardiac biomarkers like troponin?
That is a diagnostic tool, not a therapeutic intervention. It's essential for the provider to differentiate between unstable angina and a myocardial infarction later, but drawing blood does not save the suffocating heart muscle in this exact second. It is a delayed action.
And option D, observing the cardiac monitor.
Observation is passive. Watching a monitor tell you a patient is deteriorating does not stop the deterioration. You need an active intervention that addresses the supply and demand mismatch of oxygen in the myocardium.
So you've elevated the head of her bed, she's in semi-Fowler position, the oxygen demand is dropping, and you are calling for the rapid response team to get the nitroglycerin and the 12-lead ECG. The immediate crisis protocol is in motion.
Yes.
But how did this 58-year-old woman end up a hair's breadth from a massive coronary event? Let's trace this back to the absolute beginning.
We have to look at the blueprint of coronary artery disease, or CAD. This is the most prevalent type of cardiovascular disease in adults. For a nursing professional, this means you are going to see CAD everywhere.
It doesn't matter what floor you're on.
Right. It doesn't matter if you're working in orthopedics, psychiatry, or labor and delivery, you will be managing patients with compromised coronary arteries.
The most common cause of CAD in the U.S. is atherosclerosis. When I was first in school, I pictured this like pouring hot bacon grease down a kitchen sink. You pour it in, it cools, it hardens, and the pipe gets clogged. But the clinical reality isn't just a passive buildup of fat, is it?
The clogged pipe analogy is dangerous because it makes you think it is just a plumbing problem. Atherosclerosis is an active, aggressive, chronic inflammatory disease. It starts with an injury to the endothelium, the delicate inner lining of the artery.
What causes that initial injury?
It could be mechanical shear stress from years of high blood pressure pounding against the vessel walls. It could be chemical damage from the toxins and tobacco smoke, which our patient had a history of. Or it could be metabolic damage from chronic high blood sugar and diabetes.
So the lining is damaged. What did the immune system do?
It overreacts. The body tries to heal the injury. Inflammatory cells, specifically macrophages, rush to the site of the endothelial tear. But at the same time, because the patient has elevated lipids, like our patient's high LDL cholesterol, those lipid molecules seep into the damaged artery wall.
And the macrophages go after the lipids.
Exactly. The macrophages start ingesting these lipids. They gorge themselves on cholesterol, and where they swell up and become what we call foam cells.
A foam cell sounds almost harmless, like a sponge. But these are essentially the building blocks of a heart attack.
They are microscopic time bombs. These foam cells eventually die and rupture, spilling their toxic lipid-rich contents directly inside the artery wall. This triggers even more inflammation, which attracts more macrophages, creating a vicious, self-sustaining cycle. Over years and decades, this mass of dead cells, fat, and inflammatory debris forms an atheroma, or a plaque. The smooth muscle cells in the artery wall react by trying to wall off this toxic dump with a fibrous cap.
So it's not just a physical blockage in the lumen. The actual wall of the artery is diseased, stiff, and hardened. It loses its ability to dilate and constrict when the heart needs more blood.
Precisely. And if that fibrous cap tears or ruptures, The highly thrombogenic, meaning clot-forming contents of the plaque, are exposed to the bloodstream. The body instantly forms a massive blood clot right on top of the rupture, and that is what suddenly and completely occludes the artery, causing a heart attack.
That makes the risk factors so much more visceral. We're not just looking at numbers on a chart. We're looking at what is actively fueling that inflammatory fire. Let's break down the risk factor bucket, starting with the ones the patient cannot change, the non-modifiable risks.
Age is a primary factor. The risk climbs significantly for males over 45 and females over 55. Then you have family history. But notice how specific the clinical definition of family history is.
Right, it's not just a distant relative.
Exactly. It's not just having a grandparent who had a heart attack at 80. A positive family history means having a first-degree relative, a parent or a sibling who had a cardiovascular event at 55 or younger for males, or 65 or younger for females.
Race is also a documented factor, with a higher incidence in African Americans.
Yeah.
And then there are pure genetic conditions, like primary hypercholesterolemia. That is what our case study patient had.
Yes. Primary hypercholesterolemia is a genetic mutation that causes massively elevated LDL levels, regardless of how much spinach the patient eats or how much they exercise. Their liver simply cannot clear the bad cholesterol from the blood.
Now, I want to talk about the female patient factor, because for decades, heart disease was culturally and medically treated as a disease of middle-aged men.
That misconception has cost countless lives. It is true that cardiovascular events tend to occur later in life for females, usually postmenopause. This is largely because estrogen has a protective effect on the vascular endothelium. But when females do develop CAD, they carry a much higher incidence of complications and mortality than males.
A massive part of that mortality is delayed presentation and delayed care. The classic Hollywood heart attack of a man clutching his chest doesn't always apply.
No, it doesn't.
Females often present with atypical symptoms, overwhelming fatigue, indigestion, jaw pain, or upper back pain. They write it off as the flu or stress, and by the time they get to the ER, significant myocardial damage has occurred.
There is also a complex history regarding how we try to protect female patients. Because we knew estrogen was protective, the medical community long believed that prescribing hormone replacement therapy, or HRT, for menopausal women would maintain that cardiovascular shield and prevent CAD.
I see in the notes that this is explicitly not recommended anymore. Why did the guidelines pivot so drastically?
Because the long-term data revealed a terrifying paradox. Massive clinical trials, like the Women's Health Initiative, showed that while HRT does effectively manage hot flashes and menopausal symptoms, it actually increases the risk of CAD, breast cancer, deep vein thrombosis, stroke, and pulmonary embolism.
So it was doing the exact opposite of what we wanted.
Exactly. The exogenous hormones were triggering thrombotic events rather than preventing them. So for the nursing student taking an exam, current guidelines explicitly state that HRT is not indicated for the prevention of cardiovascular disease.
We have to focus on what we can change the modifiable risk factors.
Yeah.
We're talking about hyperlipidemia, hypertension, and tobacco use.
And diabetes. We cannot overstate the impact of diabetes on the vascular system. Chronic hyperglycemia acts like sandpaper on the endothelium. It accelerates atherosclerosis exponentially. Often, these modifiable risks cluster together in what we call metabolic syndrome, a patient presenting with insulin resistance, central abdominal obesity, high blood pressure, and dyslipidemia all at once.
But the clinical notes also highlight social risk factors, which I think get glossed over in standard nursing assessments. We focus on the lab values, but the sources specifically list anxiety, sleep disorders, poverty, psychological distress, and air pollution. How does air pollution cause a heart attack?
It comes right back to inflammation. When a patient inhales fine particulate matter from severe air pollution, those microscopic particles cross from the lungs into the bloodstream. The immune system attacks them, triggering a systemic inflammatory response. That systemic inflammation destabilizes the plaques in the coronary arteries.
And what about the psychological distress and poverty?
Chronic stress, whether from severe anxiety, a sleep disorder like sleep apnea, or the daily grinding trauma of living in poverty, keeps the sympathetic nervous system locked in the on position.
Fight or flight.
Exactly. The patient is constantly flooded with cortisol and adrenaline. This chronic fight-or-flight state keeps the heart rate elevated, clamps down the blood vessels causing hypertension, and promotes vascular inflammation. You cannot effectively treat a patient's coronary artery disease without understanding the environment in which they live.
Which perfectly transitions us to how we actually intervene.
Yeah.
Before we even think about the cardiac catheterization lab, we have to look at lifestyle and pharmacology.
Lifestyle modifications are the bedrock of CAD management. Health promotion programs are your first line of defense as a nurse. Let's start with nutrition. The gold standards are the American Heart Association diet or the Mediterranean diet.
I read the specific data on this, and it advocates for a heavy emphasis on plant-based foods, fresh fruits, vegetables, fish, and severely limiting processed foods and sugar-sweetened beverages. The notes even mention that a strict vegetarian diet can drastically reduce blood lipids, glucose, and blood pressure. But practically speaking, how do you tell a 60-year-old patient who has eaten steak and potatoes their entire life to suddenly become a strict vegetarian? Is that realistic?
Usually no. If you demand a complete overnight overhaul of someone's culture and diet, they will fail and they will stop coming to their follow-up appointments. Nursing education is about incremental, sustainable change. You refer them to a registered dietitian. You teach them how to read a nutrition label to spot hidden sodium and trans fats. You ask them if they can swap out red meat for fish just 2 nights a week. You meet them where they are.
The same applies to physical activity. The clinical goal is 150 minutes of moderate intensity aerobic activity per week or 75 minutes of vigorous activity. But again, you have a sedentary patient whose heart is already compromised. How do you prescribe exercise safely?
You start small, a 10-minute walk around the block, and you teach them the conversation test. It is one of the most practical tools you can give a patient.
The conversation test.
Yes. You tell them to exercise at an intensity where they can still hold a conversation with someone next to them. If they are gasping and cannot complete a sentence, they are pushing their myocardial oxygen demand too high and risking an ischemic event. If they can sing an opera, they need to walk faster.
That is brilliant. Now let's talk about tobacco. We know nicotine and the thousands of chemicals in cigarette smoke shred the endothelium. Promoting cessation is critical.
But it is also fighting one of the most powerful chemical addictions on the planet. Telling a patient smoking is bad for your heart is useless. They already know. You have to provide the tools. We use nicotine replacement therapies like patches, gums, and lozenges to manage the physical withdrawal. We also use prescription medications like bupropion or varenicline, which actually alter the brain's chemistry to block the rewarding effects of nicotine and reduce cravings.
Okay, let's open the medication cabinet. When lifestyle modifications aren't enough, or if the patient has a genetic predisposition, we bring in the heavy pharmacologic artillery to alter the lipid profile. And the undisputed kings of this category are the statins.
Statins, technically known as HMG-CoA reductase inhibitors, medications like atorvastatin or rosuvastatin, these were the absolute first-choice daily medications. They work by inhibiting a specific enzyme in the liver that is responsible for synthesizing cholesterol. The liver stops making as much, so total cholesterol drops, LDL drops, and triglycerides drop.
But earlier we established that atherosclerosis is an inflammatory disease, not just a lipid storage problem. Do statins do anything about the inflammation?
This is why statins are so powerful. They have what are called pleiotropic effects. Beyond lowering cholesterol, they have direct anti-inflammatory and antithrombotic properties. They actually help smooth out and stabilize the endothelial lining. They reinforce that fibrous cap on the plaque, making it significantly less likely to rupture and cause a sudden clot.
Now, as a nurse, you are administering these statins, and you have to monitor for adverse effects. You are checking liver enzymes because the drug works in the liver. But the big warning, the one every nursing student learns to fear, is muscle pain. Why is a patient complaining of muscle aches a potential medical emergency when taking a statin?
You are looking for myalgia, muscle ache, or arthralgia joint pain, but the catastrophic complication is rhabdomyolysis. Here is the pathophysiology of why that matters. In rare cases, statins cause rapid, massive breakdown of skeletal muscle tissue.
Which releases proteins, right?
Exactly. When that muscle breaks down, it releases a protein called myoglobin into the bloodstream. Myoglobin is a large, heavy molecule. As the blood filters through the kidneys, that myoglobin acts like thick sludge. It clogs up the microscopic renal tubules, causing acute, rapid kidney failure.
So if a patient on a high-intensity statin tells you they feel weak, their legs ache, and their urine looks dark like pee or cola,
you stop the medication immediately and call the provider. That dark urine is the myoglobin shredding their kidneys. It is a true medical emergency.
Statins aren't the only tool, though. We also have fibrates, like fenofibrate or gemfibrozil.
Fibrates are primarily used to target high triglycerides and raise HDL. However, they carry a risk of pancreatitis and hepatotoxicity. And crucially, if you prescribe a fibrate alongside a statin, the risk of developing that dangerous rhabdomyolysis skyrockets.
We also have bile acid sequestrants, like cholestyramine. The mechanism here is completely different.
Yes, these work in the gut, not the liver. They bind to bile acids in the intestine. Since bile acids are made from cholesterol, the body has to pull more cholesterol out of the blood to make more bile. The key nursing consideration here is that because it binds to things in the gut, it can bind to other medications and prevent their absorption. It must be taken before meals and spaced out from other vital drugs.
Then there are cholesterol absorption inhibitors, like ezetimibe.
Ezetimibe works at the brush border of the small intestine, physically blocking the absorption of dietary cholesterol. It is very well tolerated and is frequently combined with a statin for a dual-action approach, stopping production in the liver and stopping absorption in the gut.
Finally, we have the newer injectable biologics for patients whose lipids are still out of control. The PCSK9 agents, like alirocumab. What exactly is a PCSK9 agent?
Think of PCSK9 as a bouncer at the liver's cholesterol club. Usually the liver has receptors that grab LDL out of the blood and pull it inside to be destroyed. PCSK9 is a protein that destroys those receptors. So if we give a patient a PCSK9 inhibitor, we are taking out the bouncer. Suddenly, the liver has thousands more receptors available to pull LDL out of the bloodstream. It causes a massive, profound drop in LDL levels. They are administered via subcutaneous injection once or twice a month.
We also have the adenosine triphosphate citrate lyase inhibitors, or ACL inhibitors, like bempedoic acid.
Bempedoic acid works upstream of statins in the cholesterol synthesis pathway. It is used as an adjunct to maximally tolerated statin therapy. But nurses must know its unique side effect profile. It increases uric acid levels, which can trigger severe gout attacks, and it carries a black box warning for an increased risk of tendon rupture.
Tendon rupture. So your patient's cholesterol looks great, but they tear their Achilles tendon walking to the mailbox. You have to monitor closely. So we've optimized the diet, we've thrown every medication at the lipid panel, but the plaques are still growing. The vessel lumen is narrowing. What happens when the blood flow is tangibly impeded?
That is when the patient crosses over into experiencing angina pectoris.
Angina literally translates to strangling of the chest. But angina isn't a single entity. It exists on an ischemic spectrum.
It is a delicate balance between myocardial oxygen supply and demand. Under normal circumstances, if you go for a run, your heart works harder, oxygen demand goes up, and your healthy coronary arteries dilate to supply more blood. But if those arteries are hardened and narrowed by atherosclerosis, they cannot dilate. The demand exceeds the supply. The heart muscle begins to suffocate. That localized ischemia causes pain.
Let's categorize the types of angina, because how a patient presents dictates our emergency response. The first is stable angina.
Stable angina is predictable. The patient knows their limits. They know that if they walk up exactly 2 flights of stairs, they will get a tightness in their chest. It is consistent, it is provoked by exertion, and most importantly, it is reliably relieved by rest or by taking a single nitroglycerin tablet. The plaque is stable, it's just limiting maximum flow.
Contrast that with unstable angina, which is what we suspect our case study patient was experiencing.
Unstable angina is a massive red flag. The plaque is likely starting to rupture or form a transient clot. The symptoms increase in frequency and severity. It happens with minimal exertion, or terrifyingly, it happens while the patient is simply resting in bed. And it is not relieved by rest or a standard dose of nitroglycerin. Unstable angina is a medical emergency because it is the immediate precursor to a full myocardial infarction.
There's also intractable or refractory angina.
This is chronic, severe, incapacitating chest pain that simply does not respond to conventional medical therapy. These patients suffer immensely, and their daily functional capacity is almost zero.
Now, here is a curveball that NCLEX loves. Variant angina, also known as Prinzmetal angina.
Prinzmetal angina is fascinating because it is not primarily caused by a physical plaque blockage. It is caused by a sudden, intense vasospasm of the coronary artery. The smooth muscle of the artery literally clamps down, cutting off blood flow. It often happens at rest, frequently in the middle of the night, and it causes reversible ST segment elevation on an ECG.
So we know the types, but what does it actually feel like to the patient?
The clinical manifestations vary. It can range from a feeling of vague indigestion to a heavy, agonizing, crushing sensation deep in the upper chest, right behind the sternum. Patients often describe it as an elephant sitting on their chest.
And the pain doesn't always stay in the chest.
No, it radiates along the nerve pathways, it shoots up into the neck and the jaw, it radiates across the shoulders and down the inner aspects of the upper arms, usually the left arm. And it is accompanied by systemic panic weakness, numbness in the wrists, profound shortness of breath, pallor, diaphoresis, dizziness, nausea, and that visceral feeling of impending doom.
But wait, we cannot just look for the classic symptoms. What are the clinical exceptions? Who are the patients having an ischemic event who won't complain of chest pain?
This is a critical point for nursing assessment. Diabetic patients are the first major exception. Chronic high blood sugar causes diabetic autonomic neuropathy. It physically damages the nerves that transmit the pain signals from the heart to the brain. A diabetic patient could be having a massive ischemic event and feel absolutely no chest pain. They might just complain of mild nausea or unusual fatigue.
And the elderly population?
Gerontologic patients also present atypically. The aging process diminishes pain transmission. Older adults frequently do not exhibit the typical pain profile. Their primary and sometimes only presenting symptom is sudden dyspnea, shortness of breath. If an 80-year-old patient suddenly cannot catch their breath, you must suspect cardiac ischemia, not just a pulmonary issue.
So a patient complains of chest discomfort or sudden dyspnea. How do we assess it? We use the PQRST method to get a highly specific history.
You need to be methodical. P is for provocation and palliation. What brings the pain on? What makes it better? Q is for quality. How would you describe the pain? Is it sharp, dull, crushing? R is for region and radiation. Point exactly to where it hurts. Does the pain travel anywhere else? S is for severity. Rate the pain on a scale of 0 to 10, and T is for timing. Exactly when did it start and how long does it last?
Once we identify angina, we use pharmacology to manipulate that oxygen supply and demand curve. The frontline treatment is nitrates, primarily nitroglycerin. We know it works, but mechanically, what is it doing to the blood vessels?
Nitroglycerin is a potent systemic vasodilator. It relaxes the vascular smooth muscle. First, it dilates the veins. This means more blood pools in the peripheral venous system, which decreases the amount of blood returning to the right side of the heart. That is a reduction in preload. The heart doesn't have to stretch as much to accommodate the incoming blood.
And it affects the arteries, too.
Yes, it dilates the systemic arteries, which reduces the resistance the left ventricle has to pump against. That is a reduction in afterload. By drastically dropping both preload and afterload, nitroglycerin massively decreases the workload of the heart, reducing its oxygen demand. It also dilates the coronary arteries themselves, improving blood flow to the ischemic tissue.
Next, we have the beta-adrenergic blocking agents, or beta blockers like metoprolol.
Beta blockers block the sympathetic nervous system's beta receptors in the heart. Essentially, they put the heart in a chemical timeout. They force the heart rate to slow down, they decrease blood pressure, and they reduce the force of the heart's contractions. A slower heart that isn't squeezing as hard requires significantly less oxygen.
What about calcium channel blockers, like amlodipine or diltiazem?
Calcium channel blockers decrease sinoatrial node automaticity and atrioventricular node conduction. In plain English, they force the heart's natural electrical pacemaker to slow down. They also relax the smooth muscle in the blood vessels, causing vasodilation. They are the drug of choice for treating the vasospasms of Prinzmetal angina.
And finally, we have to treat the blood itself to prevent a clot from forming on these angry plaques. We use antiplatelet medications like aspirin or clopidogrel, which stop the platelets from clumping together, making the blood less sticky. We might also use anticoagulants like heparin or enoxaparin to prevent the formation of actual fibrin blood clots.
But what happens when the medications aren't enough? What happens when that fibrous cap on the plaque finally tears, the platelets rush in, and a massive clot completely occludes the coronary artery?
We cross the threshold into a life-threatening emergency. We enter acute coronary syndrome, or ACS.
ACS is an umbrella term that covers unstable angina and acute myocardial infarction, or MI. An MI is the actual death of myocardial tissue. When blood flow is completely cut off, the heart muscle cells begin to die within minutes. Time is muscle is the governing law of ACS. The longer the artery stays blocked, the more permanent, irreversible damage occurs.
When a patient presents with symptoms of ACS, the crushing pain that won't go away with rest or nitroglycerin, the pale, sweaty skin, the sheer panic, the clinical algorithm kicks in immediately. We rely on a triad of diagnostics, the presenting symptoms, the 12-lead ECG, and the cardiac biomarkers.
The 12-lead ECG is your fastest tool. It must be obtained and read by a provider within 10 minutes of the patient arriving at the emergency department. The ECG is a map of the heart's electrical activity. Dead or dying heart tissue conducts electricity differently than healthy tissue. We are looking for very specific changes.
What exactly are we looking for on that strip?
We might see T-wave inversion, which is an early sign of ischemia, but the massive red flag is ST segment elevation. If the ST segment is elevated above the baseline, it indicates acute full-thickness transmural injury to the heart muscle. This is a STEMI, an ST elevation myocardial infarction. It means the artery is 100% blocked and the entire wall of the heart is dying right now. We might also see pathological Q waves, which indicate that significant tissue death has already occurred.
If the ECG doesn't show ST elevation, we might be looking at an NSTEMI, a non-ST elevation MI. The artery might only be partially blocked, but tissue is still dying. How do we prove it's an NSTEMI and not just unstable angina?
That is where the third pillar comes in cardiac biomarkers. When a heart muscle cell dies, its membrane ruptures and it spills its intracellular proteins into the bloodstream. The most sensitive and specific biomarker we look for is troponin. If the blood test shows elevated troponin levels, it is absolute biochemical proof that myocardial infarction has occurred.
So we have the confirmed ACS event. What are the immediate medical interventions while we are prepping for definitive treatment?
We initiate routine, rapid protocols. We provide supplemental oxygen, but only if their oxygen saturation is actually low. Giving too much oxygen can actually cause vasoconstriction. We give nitroglycerin to dilate the vessels. We administer morphine. Morphine is incredible here because it not only provides potent pain relief, breaking the panic cycle, but it also acts as a mild vasodilator, further reducing preload. And we give a full dose of chewable aspirin immediately to halt any further platelet aggregation on the clot.
But the ultimate goal isn't just to manage the pain, it's reperfusion. We have to open the pipe.
Reperfusion therapy is the definitive treatment. The absolute gold standard is percutaneous coronary intervention, or PCI. We rush the patient to the cardiac catheterization lab. A cardiologist threads a catheter up through the radial or femoral artery right into the heart, injects dye to find the blockage, and inflates a balloon to smash the plaque against the artery wall. They usually deploy a metal mesh stent to hold the artery open permanently. The goal is a door-to-balloon time of less than 90 minutes.
But PCI requires a highly specialized lab and a surgical team on standby. What if you are nursing in a small, rural, critical access hospital, and the nearest cath lab is a 3-hour helicopter flight away? You can't wait. You have to use thrombolytic therapy.
Thrombolytics are the clot buster drugs, like TPA. These drugs do not just thin the blood, they actively dissolve the fibrin matrix of existing blood clots. It is intravenous liquid dynamite.
But using dynamite comes with massive risks. What are the indications and the terrifying contraindications for thrombolytics?
The indications are strict. The patient must have chest pain lasting more than 20 minutes that is unrelieved by nitroglycerin. The ECG must show ST segment elevation in at least 2 leads, proving a massive active blockage. And crucially, it must be administered within 12 hours of symptom onset. If you wait longer than 12 hours, the heart muscle is already dead, and you are taking all the risks of the drug with zero benefit.
Let's talk about those risks, because they're absolute contraindications. You cannot give this drug to everyone.
Because thrombolytics dissolve all clots in the body, the primary risk is catastrophic hemorrhage. You absolutely cannot give it to a patient with active internal bleeding or a known bleeding disorder. The most terrifying complication is an intracranial hemorrhage. If the patient has a history of hemorrhagic stroke or a known vascular malformation in their brain, giving TPA could cause a fatal brain bleed. Recent major surgery, major trauma, uncontrolled severe hypertension, and pregnancy are also absolute contraindications.
For the nurse pushing this medication, the level of vigilance required is staggering. You are managing a patient whose blood has temporarily lost the ability to clot.
You must minimize all invasive procedures. You start all your IV lines before you push the drug. You avoid intramuscular injections entirely because the patient will bleed massively into their own muscle tissue from a simple needle poke. You are constantly monitoring for arrhythmias because as the blocked artery suddenly opens and blood rushes back into the ischemic tissue, the heart often reacts with chaotic electrical rhythms.
And you are hunting for signs of internal bleeding.
You are watching their labs for a sudden, unexplained drop in hemoglobin and hematocrit. You are watching the monitor for a sudden drop in blood pressure paired with a spike in heart rate. The classic late signs of hypovolemic shock as they bleed out internally. If you suspect severe bleeding, you stop the infusion instantly and apply massive direct pressure to any compressible bleeding sites.
It is the absolute bleeding edge of critical care. But what happens when the anatomy is just too complex? What if the patient has blockages in 3 different major coronary arteries, or a massive blockage in the left main artery, the widowmaker? A stent won't work, TPA won't work, we have to bypass the traffic jams entirely? We are entering the realm of the coronary artery bypass graft, or CABG.
A CABG is one of the most physically traumatic and hemodynamically complex surgeries we perform. The surgical team takes a healthy blood vessel from another part of the patient's body, commonly the saphenous vein from the leg, or the internal mammary artery from inside the chest wall. They graft one end of this vessel to the aorta and the other end to the coronary artery, completely bypassing the occluded segment.
The journey to a CABG starts with intense preoperative management. We optimize their hemodynamics, ensure they are on their beta blockers and statins, and perform extensive baseline testing. But I want to talk about the intraoperative reality, because as a nursing student, understanding what physically happens to the patient in that OR explains every single thing you have to do in the ICU afterward.
The intraoperative environment is highly controlled chaos. The surgeon uses a sternal saw to cut directly through the patient's breastbone to expose the heart. To sew delicate grafts onto vessels the size of a spaghetti noodle, the heart must be completely still. They cannulate the heart and connect the patient to a cardiopulmonary bypass machine.
The bypass machine essentially takes over the function of the heart and lungs.
Exactly. The machine drains the venous blood out of the body, oxygenates it, cools it down to reduce metabolic demand, and pumps it back into the aorta. The surgeon then infuses a cardioplegic solution into the heart, which chemically paralyzes it. The heart stops beating entirely. The patient is kept alive solely by the machine while the grafts are sewn in place.
Once the grafts are secure, they warm the blood back up. The heart is restarted, often requiring an electrical shock to get a normal rhythm back, and they wean the patient off the bypass machine. Before they wire the sternum back together, they leave a few critical things behind in the chest cavity.
They place large chest tubes into the pleural space and the mediastinal space. These are thick plastic tubes connected to a suction drainage system. During surgery, blood, fluid, and air accumulate in the chest cavity. If that blood pools around the heart, it causes cardiac tamponade. The fluid physically crushes the heart so it cannot beat. The chest tubes constantly drain this fluid to prevent tamponade. They also sew temporary epicardial pacing wires directly into the heart muscle and bring the wires out through the skin. This allows the ICU nurse to immediately attach a pacemaker box if the traumatized heart suddenly drops into a dangerously slow rhythm.
And then, the surgical team rushes the intubated, deeply sedated, hemodynamically fragile patient down the hall and transfers them to the intensive care unit. This is where the post-CBG nursing management begins, the golden hours. This is where nursing vigilance is the only thing standing between the patient and death.
The sheer volume of nursing diagnoses for a fresh post-op CABG patient is overwhelming. You are managing impaired cardiac output, impaired gas exchange, risk for fluid volume deficit or overload, risk for arrhythmias, acute pain, and impaired thermoregulation.
Let's focus on the absolute priority, maintaining adequate tissue perfusion and managing cardiac output. When that patient rolls in, you have lines everywhere. You have an arterial line giving you beat-to-beat blood pressure. You have a central venous catheter measuring the pressure in the right atrium. You are watching the heart rate and the rhythm. But the notes highlight a surprisingly simple, low-tech metric that is one of the most critical indicators of cardiac function.
You are talking about the Foley catheter. You are obsessively monitoring the urine output, drop by drop.
Why do we care so much about urine when we just operated on the heart?
Because of human physiology. The kidneys demand approximately 20% of the entire body's cardiac output just to function. They are incredibly greedy organs. If the heart starts to fail, or if the patient is bleeding internally and losing blood volume, the brain initiates a survival protocol. It shunts blood away from the non-essential organs like the kidneys to protect the brain and the heart.
So the kidneys are the canary in the coal mine.
Exactly. If the urine output drops below 0.5 milliliters per kilogram per hour, an alarm bell should go off in your head. It means the kidneys are no longer being perfused. It means the patient is either dangerously hypovolemic from surgical bleeding or their newly grafted heart is failing to pump adequately. You don't just record the number, you escalate. You check the chest tube drainage for sudden hemorrhage, you check the blood pressure, and you notify the provider immediately.
You're also assessing peripheral perfusion. Because they are on a bypass machine, the risk of throwing a blood clot is high.
You are routinely palpating peripheral pulses, the radials, the dorsalis pedis. If a patient had a strong pedal pulse an hour ago and now it is absent, the foot is cold and the patient is crying in pain, an embolus has lodged in that artery. You must report it instantly. If an embolus travels to the brain, you will see one-sided weakness and pupillary changes indicating a stroke.
To prevent venous stasis in the legs, since the patient is immobile, we apply sequential pneumatic compression devices, or SCDs. We explicitly do not cross their legs, and we do not use the knee gatch on the bed because bending the knees compresses the popliteal vein and pools blood in the calves, creating the perfect environment for a deep vein thrombosis.
Now let's look at the respiratory system. Managing impaired gas exchange. The patient arrives in the ICU, intubated and connected to a mechanical ventilator.
The ventilator's breathing for them because the anesthesia and the sheer trauma of having their chest cracked open makes spontaneous breathing impossible initially.
Your first priority is the endotracheal tube. You ensure it is secure. You listen to bilateral breath sounds. You perform suctioning only as needed because aggressive suctioning can trigger dangerous arrhythmias or sudden spikes in blood pressure. You are constantly drawing arterial blood gases, or ABGs, to precisely measure the oxygen and carbon dioxide levels in their blood, adjusting the ventilator settings accordingly.
The goal is to wake them up and extubate them as safely and quickly as possible, usually within a few hours. But the transition from the ventilator to breathing on their own is terrifying for the patient.
It is a massive physiological stress test. Once the tube is out, the aggressive pulmonary interventions begin. And this requires a nurse who is firm, compassionate, and relentless. The patient has a surgical incision running down the length of their sternum. It hurts to breathe. It is excruciating to cough.
But if they don't take deep breaths and cough, the tiny air sacs in their lungs will collapse at atelectasis, and they will develop a lethal postoperative pneumonia.
So you teach them to splint their chest. You give them a foam pillow to hug tightly against their sternum while they cough to stabilize the bone. You force them to use the incentive spirometer every single hour. You turn them side to side every 2 hours. And as soon as they are hemodynamically stable, you get them out of bed and walking, even if it is just to the chair. Early ambulation is the cure for almost every post-operative respiratory complication.
Finally, we have to monitor the fluid volume and the electrical system of the heart. The surgical trauma makes the myocardium incredibly irritable.
Postoperative arrhythmias are incredibly common. The most frequent is atrial fibrillation, or AFib. The upper chambers of the heart start quivering instead of beating effectively. This drops the cardiac output and increases the risk of blood clots forming in the atria. You are managing this with antiarrhythmic drips like amiodarone or carefully titrating beta blockers.
You're also watching for right-sided heart failure. Fluid shifts wildly after being on a bypass machine. Tissues swell. If the right side of the heart is failing, blood backs up into the venous system.
The clinical sign you are looking for is jugular venous distension, or JVD. If the patient is sitting up at 45 degrees and the veins in their neck are bulging, the right ventricle is failing. You will be administering potent intravenous diuretics to pull that excess fluid off. It is a constant, minute-by-minute balancing act of fluids, pressors, vasodilators, and continuous assessment.
Wow. Okay, let's take a breath. We have covered an immense amount of ground today. We started at the microscopic level, looking at how a macrophage gorges itself on cholesterol to become a foam cell, initiating the chronic inflammatory cascade of atherosclerosis.
We discussed how lifestyle changes and statins work to stabilize those dangerous plaques. We decoded the ischemic spectrum of angina, learning how to differentiate between a stable, predictable chest pain and the life-threatening emergency of unstable angina or an evolving myocardial infarction.
We walked through the brutal calculus of acute coronary syndrome where every single minute matters, and we're reading ST elevation on a 12-lead ECG dictates massive interventions like the cardiac cath lab or high-risk thrombolytic therapy.
And we finally navigated the high-stakes, hypervigilant world of the post-CABG intensive care unit, where understanding why a drop in urine output or a sudden absence of a pedal pulse can be the earliest sign of a catastrophic physiological failure.
Everything we have discussed today gives you, the nursing student, the deep clinical rationale you need. This isn't just about memorizing pharmacology tables to pass a multiple-choice test. It is about understanding the why behind your nursing actions. When you understand the physics of preload and afterload, you know exactly why you must sit that panicking diaphoretic patient up in bed before you reach for the nitroglycerin. You aren't just following an algorithm, you are actively saving a life.
But before we sign off, I want to leave you with one and final lingering concept that challenges the very foundation of nursing assessment. We spend all our time assessing pain, the PQRST method, the 1 to 10 scale. But think about the phenomenon of silent ischemia.
Objective evidence of a heart attack, but the patient feels absolutely nothing.
Exactly. Think about the profound implications of that. Significant, irreversible structural changes, cell death, and scar tissue formation can occur in the myocardium with zero reported pain, particularly in our diabetic and elderly populations. It challenges our entire reliance on patient-reported symptoms. If the most lethal disease process in the human body can occur in complete silence, how much damage is being done before the first alarm bell ever rings? And more importantly, as a next generation of nurses, how will you assess, advocate, and intervene for a patient who looks you in the eye and tells you they feel perfectly fine?
That is a chilling and vital thought to carry with you into your next clinical shift. Trust your monitors, trust your labs, but most importantly, trust your clinical judgment. Keep asking why, keep looking beneath the surface, and keep diving deep. We'll see you next time.